Hi, my name is Pat Vijitakula, or Sorapat Vijitakula. We're from University Hospitals, Cleveland Medical Center, an affiliate hospital of Case Western Reserve School of Medicine. We're going to talk about maps in emergency medicine using geospatial analysis to understand patient utilization and population health. So our objectives is just basically to understand the basic concepts of geospatial analysis and its application, understand how to use that to leverage for emergency medical care, and also hopefully by the end of this you can figure out how to maybe inspire, how to get it to be done in your institution as well. So outline of how we're going to go through about this for the next about 45 minutes or so. We're going to introduce our team. This is just more than ER docs that are on this team. Then introduce the concept of GIS, then how we use the technology to implement it in our institution, and then hopefully there's an audience participation. You guys can throw out ideas or questions, and we can go from there. So who are we? We're lucky at our institution. We had two spatial epidemiologists, Drs. Jacqueline and Andrew Curtis. Unfortunately, they aren't able to be here today, but they are with us in spirit. And also, Dr. Jacqueline Curtis is going to be online on the Google Doc to kind of help if you guys have any questions that are really technical. And then there's us three, the emergency medicine physicians in the department, Dr. Karen Faryar. She's our research director, and she'll at the end talk about how going through about this in the research setting and using geospatial analysis and GIS. Dr. Justin Yaks, he's our division chief in population health, and he'll talk about how we'll look at a specific disease pattern, asthma, using GIS. And then me, again, Pat Vijitakula. We also worked with an OB, in the OB department as well, to kind of help looking for that field. And so Dr. Jennifer Gordon, she's a fellow there, unable to be here, but she's part of our team as well. So some disclosures. Drs. Jacqueline and Andrew Curtis, they were hired by UH Ventures. Dr. Faryar, Dr. Yaks, they're on grants from Gilead Sciences, and Dr. Faryar is also on the NIH Healing Community Studies grant, and I have no disclosures. So just for those who didn't get the paper, just the QR code, again, you guys can just pull that up. If you guys feel free to type in. We have someone monitoring the questions as well. I'll give you a few seconds. And then we can answer them at the end, and then or if some people want to wait, we can come to the mic. All right. So geospatial analysis is a tool to help detect patterns in healthcare behaviors and outcomes that have been growing across different health specialties, especially in oncology. What GIS, or Geographic Information Systems, is basically just software that uses mapping and analysis of geographic patterns at the individual and community level about their social and physical environment. So basically, in this map, in this picture here, you select an area you're interested in, and you can layer on top of other factors that might be of interest to you at the patient population level. So you can look for unknown relationships. Just kind of add, there's Basecamp, there's demographics is very popular. Look at just the environmental factors, both socially created and like the parcels and the zoning, and we put all those together, and it's just its core. And the main thing that we start with is geocoding, which is basically converting the patient's address to latitude and longitude, and then using that information, using the software to kind of look for there's clusters that are forming of disease of interest, like for instance, asthma or STIs, and then go from there. And then once you find these clusters, you kind of then look for other driving factors that can help determine what your interest or your outcome is. And then, and then you can target interventions, such like where like the mobile units can come from. That would be a helpful application. So another example of this is just using the address that's embedded in the EMR, and it's linked to the environment and where their surroundings. And then you can overlay it with the social vulnerability index or the census tracts and just information that's already collected by the CDC and put it over on top of that. And you get something kind of like what you see in the middle there. And then you can overlay something with like the EPA, like the pollution level. And then the cool thing is that then you can add local information, such like crime rate, and then you kind of get something on the right there. And so you get a very multidimensional analysis of your patient population. These are, again, just for reference, are not actual findings here. So what do I just kind of briefly, quickly told you how this tool is really great. One of the things, but how do you get it started? What are the requirements? Surprisingly, for us, at least for me anyway, was the hard part was getting like the human resources, like the human capital, getting spatial epidemiologists. I've had many conversations with the Curtis team, and they were like, no, that's too strong of a conclusion. Just trying to understand all the different layers of factors that go into it. And if that's not available at your institution, public health programs, geography, graduate programs can have these embedded in them, and they can pull, and then you can hopefully get them to train in emergency medicine specifically as opposed to oncology historically. Actually, the lower hanging fruit, the slow bar, is getting the technology side, what we found. Getting a PC that has its own secure server is kind of like what we do anyway with IT. GIS software for the licensing is about like $5,000 a year. But there's also different various levels. Some EMRs have geocoding embedded in it, and some are, the software itself can be free for QGIS, for example. So that is our secret sauce. That's how we did it. I mean, it's relatively simple, kind of like a good burger, just salt and pepper. So all these approaches is great, but to get a deeper understanding, just keep in mind that when you're looking at the data, it's just always as good as what you collect and how you interpret, right? Like any other tool. The limitation for this GIS or geospatial analysis is that the data that we collect are static, like patient's address are like at one point in time, and people move around and are dynamic. Like for example, here we get someone's home address, so this patient's home address, and then we convert it to see this. So this is all in a pediatric population that were getting lead tested, and how much they moved in about 2.5 year period. And some of them move up to 11 times in that period. And how do you check their lead exposures? It gets pretty complicated there. And also, I mean, the distance isn't that far. It's about, the longest one's about 32 kilometers, which is about 20 miles. And so they moved across different county lines as well. So that's something to consider when looking at this kind of data. And the other thing is that what we're collected traditionally with the zip codes, they're very coarse or very non-specific. They're kind of large area. People are very very granular and are specific. So trying to match those two, especially in the patient population we see who are probably on the lower side of the SES, lower income area. So to combat some of this, we're using technology of GPS. Here's an example, information that's outside the EMR. So on the left there's on the map, there's a pointer. Oh, you guys can see the map on the pointer, without the pointer. It's the official data of traffic accidents in a community. This is where they found that's the most concerning area. But if you ask, using GPS and asking the patients or the people that live in that community, what lights up is the areas that they think are concerning for traffic accidents. And this is kind of, you can anticipate potential future accidents from happening, if you will, because these are areas of concern. So that's one way of using, going around, just being the the coarse data and make it more granular. And the other question that people often ask when using geospatial analysis is homeless. How do you deal with the homeless? Right? They don't have an address oftentimes. And one method is, so on the left, they use paper to to record of where people are staying, and people in this certain population can be quite private of where they stay at. But mapping all this out and then converting to what we call the activity box to the right, that's one person and where they lived in about a 2-mile radius. And so you can actually that would be their address interpretation there. So that's the end of the technical part. Again, the QR code's up there in case you guys are coming in late or missed it. You can go on the Google Docs. And so now just bringing it to our shop, how this kind of got started, this partnership. I mean, it was started during COVID. I guess that's the one good thing that happened from COVID in our area, is that the ops team and the research team kind of merged because the ops team wanted to know real-time data of what the disease severity. And so they asked the spatial epidemiologist to create a system, which was called a GeoMed, is a spatial surveillance system that kind of looks at real-time mapping of addresses that we know are COVID positive, and looking for sentinel clusters, so potential places that could be an outbreak there, and then also look at hospitalization rates, and you can see the severity and try to do that. This is obviously early in the pandemic. So this merging of ops and research kind of continued with the low acuity ED utilization, kind of trying to do something that's more specific emergency department for crowding. And one of the things is the lower acuity and using that as a proxy of access to primary care. And we were able to get data from 2018 to 2020, looking pre and during COVID in that time. And we use subset, we collect over 140,000 ED visits, and then just because there's so much analysis, we gotta do subset analysis of around 40,000 visits, 41,000 visits, kind of to see what the utilization would be pre and during COVID. Now, in the past, people have used the social vulnerability index to kind of estimate this of how resilient a population could be. This is designed a tool by the CDC to look at if a certain community receives an insult, how responsive are they? They looked at social economic status, household composition and disability, minority status and language, housing and transportation. So using that has been kind of what a lot of people are using. What we found when we mapped in our area in Cleveland, the darker areas is the area that's kind of higher and most vulnerable population. It's more urban in that area. And we found there's no change in low acuity ED utilization prior to COVID and during COVID. So that metric is a tool that's kind of helpful. But when we expanded to the rest of our UH catchment area and more rural areas, when we look to the east, in Conneaut, for example, it's still dark, saying that there is vulnerability is high in that area. However, we found that the ED utilization for low acuity actually increased during COVID, suggesting there's differences in needs of these two populations, and that there's no single resource or intervention that will fix both. Getting access to primary care is not just it has to be more specific than that. So that's just one part of it. And so just basically just conclude that the primary care access needs differ in the rural and urban areas, and we have to, and this tool can kind of help get more granular of what's going on. And the geospatial maps has been an effective way. I was able to communicate in 2 maps basically what we kind of did and how our patient population is looking, kind of like bedside ultrasound. And that's kind of the power of it. So I'm going to, next person, Dr. Yaks, I'm going to have him talk about how we use geospatial analysis for a disease like asthma.
Can everybody hear me in the back? Great. Thanks, Pat. That was great. My name is Justin Yax. I am the chief of the Division of Population Health at University Hospitals Cleveland Medical Center in Cleveland, Ohio. So Sorapat just described how we're using geospatial technology to help us with operational aspects of our emergency department and how to utilize resources strategically during COVID and then just in general. We call this study the Asthma Risk Score Study. It'll probably get a more fancy title as we go, but this is going to give an example of how GIS can actually help with non-communicable diseases in our community. So Cleveland's a very good place to study asthma. As if you may not know, the Asthma and Allergy Foundation of America has ranked Cleveland as number 6 in the USA for the worst cities to live in if you have asthma. And this is based on asthma prevalence, asthma-related emergency department visits, and asthma-related deaths. So it's a very appropriate place to study asthma. And as we know, the emergency department is the gateway to our communities, right? And to get the information from our community is not always the easiest thing, right? We can sit there and we can talk with a patient, and we can get some information from the EMR, like their age, their sex, their race, their smoking status, their compliance versus non-compliance status. But there's some data that may not be typically obtainable, and so I'll first go over the different levels of data that we're using specifically for the asthma study. Sorapat showed you the map with multiple layers. And I like to think of things like there's individual level data that a patient experiences. There's household level data, the data that kind of comes from their household, their microenvironments. There's community level data, which is data within their community. And then there's even higher than that, which let's say it's geographical, which would be things like weather changes, pollen count, if you're going to talk specifically about asthma and the effects of it, right? And how do we go about and how do we get this otherwise elusive, household level data? And we've come up with a solution, something called a geo-narrative. And I'll just say a quick word about that. A geo-narrative is where we actually have this concept where we would go into the community and we would examine for example, a community health worker that is expert in that local community to go in, and we would do geo-narratives, which are essentially riding in a car with your GPS device, recording a narrative, kind of a semi-structured interview. And then you would develop a map that has very points of interest, and you would link those points of interest to various keywords that were said in the interview. So you could say in one particular part of town, this well-versed community health worker that knows that community backwards and forwards would say, this group of houses over here has a hard time getting their medicine because the pharmacy is 20 miles that way. And, so it's important to pick the right person for this interview, because the more in-depth knowledge they have of that community, the better your variables are going to be obtained, right? And again, these are the data points that we just can't get as emergency medicine docs. And so you can kind of see the overlap of public health with emergency medicine here. Explaining this slide, you'll see the slide on the graph on the right here will show the red and the blue lines are our UH. We derive this data from our UH EMS service. Dr. Jeffrey Luke, the head of our EMS department, has really graciously helped us get this data. But we can see the number of EMS runs for asthma exacerbations that requiring 911 calls in 2019 and 2016 and 17 are the red and the blue lines, and then 2018 and 19 are the gold and the gray lines. So we can say just from this graph that whatever we're doing in Cleveland, the incidence of asthma EMS calls is rising, right? And so what do we do to help mitigate that? And you can see on the left here, I show examples of the EMS, the levels of data that we're going to obtain, and then also the modality of how we obtain them, right? So individual level data such as age, sex, comorbidities, use of corticosteroid inhalers, right? Those can be obtained from medical records. Also know that individual level data does include the address where the patient lives, so we could get that from EMS runs, for example. Household level data is a little bit more difficult. It's things like pest exposure. We know that has an effect from studies on asthma. We know that family structure, like single parent households, have a higher incidence of asthma because you're too busy taking care of your kids to go to the pharmacy and pick up your medicine. But that's not always in the chart, and that would be really helpful where we do these geo-narratives. Community level data such as access to pharmacies. How far are the pharmacies away from this person's house? Health literacy. Do they have transportation to their PCP? These can be obtained through either the geo-narrative interviews, existing GIS maps, or the U.S. Census data. There's multiple maps out there already that are available for you so that you can overlay on top of your data, such as where violence exists in your city, for example, or where the income distribution is, right? Perfect. So once we analyze the EMS data, as what Dr. Sorapat was saying, you have your point that you put on the map of one particular EMS run, but once you start getting 10,000 of these points, you start seeing these areas of high concentration, right? We call those hot spots, right? So we know, and we're very lucky about this because Cleveland is a city that has 3 major hospital systems in it, and University Hospital is one. But our EMS systems, we have 100% of the runs in our EMS systems for any given city. If UH-EMS is in charge of that one city, we know 100% of those runs and what they were for. Those runs may go to different hospitals, but we know that if a person gets called 911 for asthma in a city, we know that we get 100% of that data, and we can plot that on a map. So then we get a map like this. Now, inside these 2 circles are basically are the areas with consistent high-density asthma exacerbations over the 5 years of data that we have. Now, what's interesting is inside of each of these circles are tinier circles that show like higher concentrations in micro populations where the asthma exacerbations are higher, but we can't show that simply for patient confidentiality reasons. The more granular you get, the more difficult it is to share this data, but you get the point, right? Good. Moving on. So on the left, we see kind of this is a picture in the box A. We see basically a steering wheel, and that little yellow box has a kind of a focus on a GPS system. So this is basically an example of what the geospatial narrative will do when you're riding around these communities, right? That you have your hotspots in. Because once you have the hotspots, now you can focus your resources on exactly where you need to, right? You're not wasting time and money on focusing on communities that may not have high asthma concentration. So that's the first utility. When we go to these communities and we have these geospatial narratives, this is what we come up with in terms of the product. We have a map. This is a Google map. You can see those little red pins are points of interest that correlate to keywords said during the recorded narrative, the recorded interview with the community health worker. So we can go back and reanalyze this, and we can say, well, this red dot here, this is where the community health worker mentioned that there was maybe a group of houses that were a little bit more, had a high pest exposure or something similar to that, right? The graphic that you see on the right, this is an example of how asthma is a multivariate problem. Most likely, we believe that asthma is a multivariate problem. We see the GIS community currently has a lot of maps that kind of go down to the community level and describe like large populations and things. And then we have our individual studies which give univariate analysis of asthma and what risk factors there are. For example, there's plenty of studies on asthma and the risk of smoking, obesity, how that contributes to asthma exacerbations, the lack of use of corticosteroid inhalers. These are all univariate issues, but if you look at this graph, this kind of tries to portray that asthma is a multivariate problem with each of those spokes on that wheel, one of the variables that I just mentioned, in each color you can see reflects how that data can be obtained. So you see, for example, in the areas in blue, those are going to be obtained by the geo-narratives, and those are such things as stress exposure, pest exposure, things like that. The orange are things that EMS data can obtain. These are the time of day, the time of year of the actual 911 call, which would correlate to the time of the asthma exacerbation. Right? The green is obtained from the electronic medical record. This is the things that we all know: age, sex, race, smoking history. And then the violet or the purple shows these can be obtained from the geospatial map, and these include things like the social determinants of health, the socioeconomic status of an area, et cetera. Good. And this is basically how the data is analyzed in our study. We take each of those layers of data, each that was collected by a different modality that I just mentioned, and they basically undergo. GIS has the ability to actually take hundreds of data points and weigh them accordingly so that they can do what's called a geographically weighted regression to develop a model that's based on the data we collect. Okay, and this eventually will come up with a common risk patterns that contribute to asthma exacerbations, and our goal is to come up with something similar, something kind of resembling an asthma score that will point a clinician to not only the risk of recidivism for that patient for an asthma exacerbation over a given period of time, but also what will contribute, what risk factors can be mitigated for that. So that's how we envision this to happen. Now, what are the things that this can potentially do? Well, we're not going to cure poverty, right? We're not going to cure we may not even be able to cure someone's like smoking habits, right? But if there's things that we can find, such as I can't get my medicine because I don't have a card to go to the pharmacy, right? And we know that this person lives in a pharmacy desert, I suppose we could call that. Perhaps we establish clinics in these areas, pharmacies in these areas that might help people gain access to their medicines. Or perhaps we sponsor a hospital-based home medication delivery system for very specific patients that have a high risk of recidivism if they're not getting their medicines. Or do we just simply pay someone to have a 24-hour pharmacy in our emergency room, so that the people can get their medicines before they leave, right? Or is it something as simple as just providing extra refills on medications and dispensing, 5 refills on their asthma medicine? We don't know yet. But then this brings in the whole community health worker. This is a great concept, and a lot of hospitals are starting to get these community-based health workers. So what if it's simple as having a community-based health worker and support that system where these people can go out into the communities, help with healthcare literacy, help increase healthcare literacy, perhaps help with smoking cessation programming, weight loss, things of this nature. This is an example of how we are studying in our community non-communicable processes, and this can be you can see the extrapolation to this to hypertensive emergency, DKA. So a lot of promise here. And next, I will pass it along to my colleague, Dr. Fire, our research director, who will talk about gynecological care and how we're using that in GIS.
Hello, all. Thank you for coming. So another example that we wanted to highlight was using GIS in looking at gynecological care. So we actually partnered with a gyn-onc fellow in our health system who was very interested in gyn-onc diseases. One of the things that we noticed with the ED utilization study is we had a large number of females coming in presenting with low acuity gynecological complaints, right? And I think we all probably see that if we work at academic centers. STI complaints, pelvic pain, pelvic discharge, things like that. So when we were analyzing the low acuity ED visits, we saw a very large subgroup who came in specifically for this. Our gyn-onc colleagues noted that a lot of the patients that end up having oncology diagnoses down the road had many prior ED visits for these types of complaints. So this seemed like a really rife opportunity for not only evaluation but also intervention. So we know this is a problem, and we know there's a lot of reasons for why these patients come in, right? It's demographic, socioeconomic, geographic, right? They may not have either primary care provider or a primary OBGYN within their area. So again, they're using the ED as their primary care resource. And so adding that one linkage to care component through the emergency department, we thought could really help to intervene before these patients end up with a full oncology diagnosis. And we wanted to use GIS to not only help to identify these patients, but also really to meet them where they were at in their environment. So as an example, this is very similar to the maps you saw for the previous examples. So the two areas in red are areas that have lower income and had a high density of specifically African American females who use the emergency department for low acuity gynecological complaints. And so the idea being, and this is something that we're actively working on, is you would identify one of these patients in the emergency department, and if you were able to see that they were in one of these areas, rather than printing off your kind of general health system discharge instructions, you could find them an OBGYN in their area within maybe 2, 3, 4 miles. You could also overlay the city's bus routes on that discharge instructions, right? And say that you could go to this specific health center using this route, if you don't have access to a private vehicle or somebody who could take you. And there's just making more personalized discharge instructions than the ones that our EMR usually spits out was another potential opportunity for GIS to really help with not only health disparities and just improving the health outcomes of our patients. As we mentioned, I'm also the research director of our department. So we kind of talked about like step one, right, was our secret sauce of the personnel resources and the programmatic resources. Step two is our favorite part of all research, is our IRB. We have a particularly conservative IRB, and so we definitely found that there were some small barriers to kind of overcome when we started doing GIS research. The biggest one is that we were asking for large volumes of patient information, right? Large volumes of patients in order to get their addresses. Our IRB template puts a max of 500 patients, and we wanted to look at tens of thousands. So there was a lot of red flags that went up from their side of things. I would say this is definitely a great opportunity to have that meeting with your IRB specialist to really explain, because I think this is pretty new technology, and they just didn't understand like what the purpose of this was. We made it very clear that while we are individually geocoding each patient, when we present the data, like we did here in manuscripts, it's going to be at the cluster level, right? There's not going to be any individual patient addresses that we'll be presenting. That by grouping it and clustering it, you protect the patient health information. So that was one of the barriers. The other thing that we kind of saw that really helped also overcome that barrier was we submitted an initial QI/QA protocol, and COVID actually kind of helped with that because we were able to filter this through a QI/QA lens, and then they, again, got a better understanding of what we were actually doing and how we would be presenting this, and again, not using PHI. And then we were able to take it to that next step of the research interventional protocol, and they had a better understanding, so it raised a lot less flags, and it was easier to get through that way. And then step three is the interpretation and the implementation. And we've been kind of monitoring the chat, and a couple people asked about that, like how do I use GIS for my patient with chest pain, right? Like what is GIS produces some beautiful maps of various different colors, but then what do you do with the maps? And so things like providing pharmacies in areas where you need them, or the linkage to care interventions, or the personalized discharge instructions, like those are ways that you can really integrate GIS to help you with the patient that you're seeing in front of you, at the bedside or when you're going to discharge them. So with that, we wanted to go ahead and conclude. I think our conclusions are that GIS exists, it is useful, and it is possible to implement in your shop. Let me know if you guys have any questions. Like I said, we've been monitoring the chat. I also wanted to introduce via Zoom Dr. Jackie Curtis. I'm going to take her. Can you unmute yourself, Jackie?
Somebody's comment in the Google Doc. So, hi everybody. It's nice to see you. Gosh, I wish I could have been there. But please do continue putting your questions in the Google Doc. It's a live document, so I can continue to respond to things as your questions arise. But I'm just super appreciative of this collaborative team. We have done so much in a short amount of time and have so many things ahead of us, and we're really excited about the work we're doing. Feel free to ask any questions of me too. I'm sure my contact information, email, and such are in the program information. So please do. I welcome all questions. Thanks.
Case in point.
So great. This is Rita Manfredi from George Washington University. So this is for the person on the computer and the three clinicians. Tell me how you would use GIS with palliative medicine. Maybe advanced directives, stuff like that. Appreciate your response.
Thank you. I can take that first. Yeah, I think Jackie was starting to answer this on the chat, but I was actually thinking about it too. I was thinking of using the GIS to kind of like see, using our EMR though, see what end-of-life goals are, and then see what the distribution in the community can be, and then like using interventions, the community health workers, like, it's a thing. Like, this is something you should talk about with your family members. That's something that I would like to do, because at least for me, when I got out of residency not too long ago, but like, I knew how to run the codes, but then like I could never know when to run the codes. That was like the hardest part about being an attending. And so that's actually a subject near and dear to my heart, just trying to figure out how, we can look, and then we haven't done it yet, so I suspect the same stuff, the higher vulnerability index would probably have lower rates of palliative care, end-of-life goals and that nature, and just understanding what palliative care is in general. So that would be a great way for an education where we can target people instead of having a generalized, like, an information session.
Yeah, I think to add to that, I'm sorry, Dr. I didn't see you. I think to add to that too, we were talking about, like as an example, when we talked about the maps where we looked at homeless patients. So, for that we would maybe add on shelters in the area, or, food banks. So for your specific palliative care example, you could add on where are the hospice centers, right? Or where are the nursing homes that have inpatient, or hospitals that have inpatient hospice or palliative care. So you could add kind of that geographical component to, this is where my patient lives, this is where my patient's PCP is, this is where their hospice is, and kind of form this aerial, kind of spatial map to show this is where it would be most convenient for you to go, and again, just laying on those community resources.
Thank you for that question. I have a kind of a research project going in my head just from you asking it, but I think what would be very useful is to start with, we all see stage 4 cancer presenting initially in our emergency department, right? We all see people who come for DKA or for congestive heart failure with an EF of 15%, like, come back all the time. So, you could run a study, where are these patients coming from? Show me, get your ICD-10 codes for your end-stage diseases, and then cross-reference that with how many times they're coming over a short period of time, and there's your target population, right? And then maybe there's, and we all know that this is a very cultural kind of, it's a very touchy area, right? So, but at least you'll have your population that you can address, right? And then how you go about from there, I think, is going to be very dependent on the population you're serving. Does that make sense? Yeah.
All right, Dr. Michelson.
Thank you. Ed Michelson from Texas Tech, El Paso, previously from Cleveland. Nice presentation. Two thoughts. One, with the EMS data, looking at asthma, for instance, and where EMS picks up patients with an asthma exacerbation, I think it would be interesting to look at that normalized against all EMS runs. In other words, what % of EMS runs are asthma versus other reasons that EMS is called when you look at those different areas, to see whether it's disproportionately asthma versus the multitude of other reasons people call EMS, and see whether you could identify different areas of the city that had a higher or lower % of all calls being asthma.
Yes, that's a great point. So our plan eventually, right? And this is, of course, is the 10-year plan. And this can be done with any city in the country, really. And every study is going to be different, but what if we took all end-stage diseases, right? What if we took end-stage asthma, which is, an asthma exacerbation is essentially the end product of uncontrolled asthma. DKA is a product of uncontrolled diabetes. Hypertensive emergency is an end product of uncontrolled hypertension. And then we take it, then again, as Pat showed, each one of those is a layer, and then you look down on that layer and you see, oh, well, maybe these are all in the same area, right? We don't know. We just don't understand our population as good as we should. And the first step is to know that, and the second step is to, this is a great tool to, I think, help us. Does that answer your question?
Sort of. I just think there might be some additional value to not just seeing where heart failure patients come from or asthma patients come from, but which ones have a higher % of total calls related to that one disease entity.
Sure. No, that makes sense too. Yeah. And in a particular given population, you mean in a city?
Right.
Yeah.
And then the other quick thought is, I know that although you're the preeminent provider of emergency services on the east side of Cleveland, that there's another fairly well-known entity about 2 miles down the road. Have you looked at where people go In other words, for the same problem, how do they distribute across different providers in your community?
So we do have that data. We just haven't looked at it yet. There's a lot of stuff to do, but it's exciting. It's an exciting field.
Good.
Hi, thank you for the nice presentation. I guess I have a question about when you're dealing with data sets that are at different levels, a patient level and a geographic level, don't you run into issues with the ecological fallacy, the idea that you're making a generalization at the patient level based on where they live and the aggregate of all of the people that live in that area? That may not actually be true, right? There's going to be variation at the person level that is not going to exist at the aggregate average level for the place they live in. So how do you account for that in this kind of analysis? Thank you.
Sure. So, team, I can't see your faces, so I'm going to ask if I can just jump in and answer that.
Sure.
So, the ecological fallacy is inherent in any spatial epidemiology, as is the modifiable area unit problem. So, the way we decide to carve up geography can influence our results. But as your question was about ecological fallacy, let me just jump in on that one. So it is always present. If you're taking point level EMR data and then you are associating it or aligning it with census tract level data, for example, and modeling those relationships, you can't get away from the ecological fallacy existing, but the way that you can handle it is your interpretation of the results. Whenever you're doing that, whenever you're taking point level patient EMR data and you are trying to analyze it with community level environmental socio-demographic data, you have to interpret it as the relationships are about where the patient lives, not about the patient. So these are factors or characteristics or variables that may serve as risks, protective factors, resources, assets, etc., of the community around this home address, not about the patient themselves. And I study ecological fallacy, so and error in the census data. So I'm very happy to go down a very deep rabbit hole with you at some point if you want to go through all of the ways that this can confound and trouble what you're doing. But there are some really good papers out there on that, which if you email me, I'm happy to link you to.
No, thank you so much, Dr. Curtis. And I think I would add, and I don't know if this is perhaps cliche, but I think this is done where the art of the clinician comes in, right? Like, yes, I know this patient lives in this geographic area. With the GIS technology, we know the community, what they have access to, what they don't have access to, but then kind of taking that to the individual patient level and saying, these are the resources that I know that are in your community. Do you have access to them? Yes or no? And maybe, like you said, maybe they do. Maybe they're not necessarily as much of a product of their environment as their neighbor is. So I think this is, again, just one more tool in understanding your patient better, but does not negate the individual patient encounter, if that makes sense. So Dr. Curtis has been, sorry.
So just one quick note, because I work in a similar area. One way around ecologic fallacy, which probably you're already doing, but to word it out, would be that you're not looking at causality. You're not saying that this is causing this. You're looking at a correlation. Mm-hmm. So in a way, you're taking care of ecologic fallacy there, because you're not looking at cause and effect, but rather a correlation of factors.
Yeah, that's a really good point. It's 3:47. We want to be cognizant of time. We know there are a lot of questions on the Google Docs that where half of them were answered, and then when Dr. Curtis joined on, the other half were not. So we will continue to monitor this and answer the questions through that and just have this be kind of a live chat forum. But I'm sure there's another presentation outside waiting, so we don't want to keep them. But thank you so much all for coming.